Hello, this is Brad, and this is my ortho peer competency. Okay. So, some of my hypotheses as to why this patient is experiencing pain are that there's some involvement of the inert tissues around the T7 costotransverse joint, um, and more likely the anterior uh, capsule of the joint, backed up by pain during his functional movements that involve extension and rotation, which would stress the tissues such as sitting and standing up straight, and then rotation during his golf swing. And then this is also backed up by some clinical exam findings such as thoracic extension, right rotation, and unilateral PA to the right costotransverse segment at T7, which I'll recreate P1. These would all be stressing the anterior capsule, the inner tissues of the anterior capsule. And then I also just added that there possibly will be more involvement of other thoracic levels, because there's one of the exam findings was grade 1 hypomobility throughout the upper thoracic spine. So that's my primary hypothesis. Other things that might be causing pain are a strain of the erector spinae muscles, which contract when you're sitting or standing up straight. So if those are strained, you might get some pain with that. But some of the pain was reproduced with passive range of motion. So I thought this was less likely than the inert tissues. And then similarly, strain of the intercostals because he has pain with breathing. Possibly a rib fracture would also cause some pain with breathing. So then other tests that I might want to do are get some more subjective information from him. So ask him more about his heart murmur. If he's been to his doctor recently, got an ECG recently, and if there's anything he's doing to manage it, along with that, checking vitals as part of best practice, so heart rate, blood pressure. I would also want this patient to explain more what he means by a family history of bad backs. So if he knows details about like what he means by bad. And then I would also want to ask him when his pain gets up to an 8 out of 10, like what he's doing or if it's a certain time of day. Other examination that I'd want to do is a posture assessment to see if there's any malalignment throughout his spine, a pulmonary screen because he has pain with deep breathing. I'd want to do some more active range of motion, passive range of motion of the thoracic spine. So thoracic extension, passive range of motion, just to make sure that it's not any contractile tissue. And then side bending, based off of the other exam results, I would expect that side bending to the left might cause some pain. So I'd want to just double check that. I'd also do some lumbar active passive range of motion with overpressures because of regional interdependence. So problems in the lumbar spine might be causing problems in the thoracic spine or vice versa. Based off of some of the things that the patient reported, such as worrying about having a torn muscle, I would want to have him fill out the FAB-Q just to see how he cognitively thinks about the pain that he's having and if it's affecting any of his movements. And then I'd also screen for depression because he has a family history, possibly a lower extremity neuroscreen, just like a quick dermatome or myotome assessment, just to make sure there isn't no spinal cord involvement. I feel like it'd be efficient enough to do a quick one of those. I think this patient is appropriate for physical therapy. I did not see any red flags to indicate that there might be a fracture. or a malignancy. I didn't see any risk factors, and he noticed the pain when he was sitting on an airplane, so there wasn't really a mechanism of injury for a fracture. So I think he is appropriate for PT. So the SIN classification, I put him at a low severity because he said symptoms don't limit his usual function. As far as irritability, I said acute irritability at T7 because there was pain before resistance, subacute irritability at T6 because there is pain at resistance. And then as far as a functional classification, I said chronic because he said that pain follows various vocational tasks or workouts. So it seems to happen after he's done a bunch of activity. As far as the nature, I said mechanical because P1 is reproduced with movement. Overall, I think he has a good prognosis for physical therapy. He has minimal comorbidities, which is my main reason for saying that. I think therapy, although there is lacking evidence to support, at least from what I saw, there's a lack of evidence to support interventions for if there is a dysfunction in the costotransverse joint. But in this case, so I think the clinical equipoise may play a larger role. So if the therapist is confident in their treatments and the patient can sense that confidence, I think the patient can still get better with the interventions. And then the therapist may also want to pay close attention to how they're talking about pain, maybe doing some pain education, just because of, again, some of the things that the patient reported, such as worrying about having a muscle strain and family history of bad backs. So, and here are some sources that I used for the prognosis.